Welcome, everyone. I'm incredibly excited to dive in with you today.
Yeah, same here. It's a great topic.
It really is. We have a fantastic custom-tailored journey ahead of us. If you're joining us right now, you are probably maybe prepping for a big operational meeting or catching up on the latest regulatory compliance standards, or maybe you're just insanely curious about the invisible rules that govern our most personal data.
Right. The data that basically defines us.
Exactly. Whatever brings you here, welcome to this deep dive. Our mission today is to demystify a massive, complex, and widely misunderstood topic. We are talking about HIPAA.
And just to be absolutely clear on the pronunciation right out of the gate, since you'll hear us saying it quite a bit today, that is HIPAA.
Yes, HIPAA. And we are also going to be talking extensively about PHI, or protected health information.
It is genuinely great to be here with you to unpack all of this, because this is a topic that touches literally every single person who has ever visited a doctor, filled a prescription, or engaged with the healthcare system in any capacity.
Which is everyone.
Literally everyone. But despite how universal it is, it's surrounded by this thick fog of confusion. And I think it's important to start by saying that privacy isn't just some administrative legal hoop that hospital executives have to jump through to avoid getting sued.
Right.
When you really get down to the core of it, privacy is a fundamental part of patient safety. It's a core pillar of human dignity. When people are seeking medical care, they are often at their absolute most vulnerable. So protecting their information is quite literally about protecting them.
I really love that framing. It really grounds the conversation. And while we are definitely going to cover the foundational laws, the specific security rules, and yes, those shockingly high real-world financial fines that are making headlines in 2026.
The fines are staggering this year.
They really are. But this deep dive has a unique, custom-tailored focus specifically for you, the listener. We are going to examine how these incredibly strict privacy laws apply to the world of medical patient transportation.
Yeah, the logistics side.
Exactly. We're talking about the drivers, the dispatchers, the complex logistics networks that get patients to and from their critical care appointments.
Which is a brilliant and just fascinating intersection to explore.
Yeah.
Because you have the rigid, highly regulated, incredibly sensitive world of healthcare colliding directly with the fast-paced, inherently public, and unpredictable world of logistics and transportation.
It's a volatile mix.
It is. I mean, it's one thing to secure a server in a basement, right?
Yeah.
It's an entirely different challenge to secure patient data in a moving vehicle navigating through city traffic.
Exactly. To do this right, we are pulling from a massive stack of sources today. We have official fact sheets from CMS, the Centers for Medicare and Medicaid Services. We're looking at deeply detailed CDC public health law documents.
The real dense stuff.
Oh, yeah. We have the comprehensive list of safe harbor identifiers from California's Department of Healthcare Services. We are digging into exhaustively detailed telemedicine and right of access compliance guides for 2025 from Accountable HQ. And this is the big one, we have the absolute latest updated legal records of HIPAA violation fines for 2026 from the HIPAA Journal.
It is a literal mountain of data.
It is. But our job is to extract the most important nuggets of knowledge for you and translate the legalese into plain English.
It's a lot of material, I won't lie.
Yep.
But when you start to connect the dots across all these different regulatory bodies and compliance guides, a very clear, almost architectural picture emerges about how information is supposed to flow. And critically, where the most dangerous and expensive leaks tend to happen.
Okay, let's unpack this from the very beginning. Let's build the foundation. What exactly is HIPAA? According to our public health law sources, it was signed into law on August 21st, 1996 by President Bill Clinton.
1996.
Oh.
A long time ago in tech years.
A lifetime ago. And I find the acronym itself fascinating because it originally stood for the Health Insurance Portability and Accountability Act. That word portability seems to be the forgotten stepchild of the law today. Why was that the lead word back in 1996?
Well, that historical context is so crucial for understanding why the law is built the way it is. Think back to 1996. The internet as we know it was in its infancy. Medical records were overwhelmingly physical.
Right. Massive walls of color-coded manila folders in the basement of every clinic.
Exactly. But the workforce was changing. People were starting to change jobs more frequently. The portability aspect was actually the primary political driver of the bill. The goal was to ensure that if you left your job, you wouldn't lose your health insurance, and you wouldn't be denied coverage for pre-existing conditions by a new employer's insurance plan.
Okay, so making insurance portable across state lines and career changes.
Exactly.
So where did the privacy stuff come in?
Well, the lawmakers in 1996 were surprisingly forward-thinking. They realized that to make insurance portable, the healthcare industry was going to have to start transmitting claims, billing information, and patient histories electronically. They could see that digital wave coming.
They knew the paper folders wouldn't last.
Right. But they also realized that if all this incredibly sensitive health information was going to be zipping back and forth across these new digital networks, there had to be a unified federal standard to protect it from widespread fraud, theft, and exposure.
So that's the accountability part.
Yes. Over time, that accountability part of the acronym, specifically the privacy and security rules that were rolled out in the years following the initial act, has completely eclipsed the portability aspect in the public consciousness. Today, when someone says HIPAA, they just mean privacy.
So the structure of the modern HIPAA law really rests on what we can think of as three main pillars. I know the sources go into agonizing detail, but can you give us the high-level view of what these three pillars actually are?
Absolutely. The first pillar is the privacy rule. This is the broadest and arguably the most foundational one. It establishes the national standards for the protection of what we call PHI, or protected health information.
Okay.
And the key thing to remember about the privacy rule is that it is medium agnostic. It protects your PHI in all of its forms. We are talking about electronic data on a hard drive, paper records locked in a filing cabinet, an X-ray film in a manila envelope, and even verbal conversations happening between a doctor and a nurse in a hallway.
Right.
It all falls under the privacy rule.
So it's the overarching philosophy of keeping secrets secret, regardless of how they're stored. What's the second pillar?
The second pillar is the security rule. This one is much more specific and technically focused. It deals exclusively with electronic PHI, which the industry refers to as ePHI.
Got it.
It mandates that entities must ensure the confidentiality, integrity, and availability of this electronic data. It forces organizations to implement very specific administrative, physical, and technical safeguards.
I want to break that down because when you say technical safeguards, I assume we are talking about complex passwords, two-factor authentication, military-grade encryption for servers, stuff like that.
Yeah, firewalls, exactly.
But what do physical and administrative safeguards look like in the real world?
Great question. A physical safeguard is exactly what it sounds like. It's the lock on the server room door. It's the security camera in the IT department. It is the policy that says you cannot leave a laptop sitting on the passenger seat of your car. It is physical access control.
Okay, and administrative.
An administrative safeguard is about human behavior and corporate policy. It's the mandated training sessions every employee has to sit through. It's having a designated privacy officer on staff. It is the protocol for how you terminate an employee's system access the moment they quit. The security rule recognizes that the best firewall in the world is totally useless if a disgruntled employee still has their login credentials 3 weeks after being fired.
That is a terrifyingly valid point, and I assume the third pillar deals with what happens when those firewalls or physical locks fail.
Precisely. The third pillar is the breach notification rule. This dictates exactly what must happen when the worst-case scenario occurs. If there's an impermissible use or disclosure that compromises the security or privacy of the data, the entity cannot just sweep it under the rug.
They can't just hide it.
No, they are legally required to notify the affected patients. They must notify the Secretary of the Department of Health and Human Services. And, this is the kicker, in cases involving more than 500 people, they are legally required to notify the prominent media outlets in the state or jurisdiction where the breached patients reside.
Wait, they have to call the local news and tell on themselves?
Yes, they do.
Yeah.
It is essentially a forced public shaming mechanism designed to ensure accountability. And they have to do all of this without unreasonable delay and absolutely no later than 60 days after discovering the breach.
Let me play devil's advocate here for a second. 60 days sounds like a long time to a patient whose data is floating around the dark web. But from a corporate standpoint, 60 days must move incredibly fast when you're conducting a full-scale forensic IT audit to figure out exactly which servers were compromised, right?
Oh, it is a brutal timeline for an IT department. When a sophisticated ransomware attack hits, the network is in total chaos. Figuring out exactly whose files were exfiltrated versus which ones were just encrypted in place, that takes massive forensic resources.
Right.
But the law prioritizes the patient's right to know so they can freeze their credit or monitor their medical identity. The 60-day clock is a strict federal mandate. And as we'll see later when we talk about fines, missing that deadline is a very, very expensive mistake.
Okay, before we get into the massive fines and the breaches, we really have to talk about who actually has to follow these rules because, and our sources highlight this, there is a huge, almost comical public misconception that HIPAA applies to literally everyone in the country.
Yes, it is everywhere.
You see it all the time on social media or in public. If a manager asks an employee why they called in sick, or a cashier at a grocery store asks a customer what their knee brace is for, people will confidently shout, "You can't ask me that. That's a HIPAA violation." Let's clear the air here. Legally, that isn't a HIPAA violation at all, is it?
No, that is easily one of the most common and persistent misunderstandings out there. People use HIPAA as a synonym for general medical privacy. But HIPAA is a highly specific statutory framework. If an organization or an individual does not fit the legal definition of a covered entity or a business associate, HIPAA legally does not apply to them, period. End of sentence.
So the grocery store cashier.
Your boss asking about your cough is not a HIPAA violation. A restaurant asking for proof of vaccination during a pandemic is not a HIPAA violation. They are not covered entities.
So who exactly is in the club? Who is a covered entity?
The CMS guidelines are very explicit, and they divide covered entities into 3 distinct categories. First, you have healthcare providers. But there's a caveat here. It only applies to providers who transmit any health information electronically in connection with certain standard transactions, like billing Medicare or private insurance.
But in the modern era, that is virtually every doctor, clinic, psychologist, dentist, chiropractor, pharmacy, and nursing home, right?
Basically, yes.
What if a therapist only takes cash and keeps all their notes on paper? No digital billing at all.
Technically, if they have never transmitted a covered transaction electronically, they might not meet the strict definition of a covered entity under HIPAA. Now, state privacy laws and professional ethics boards would still heavily regulate them, but practically speaking, in 2026, almost every provider is a covered entity.
Okay, so providers are Category 1. Who is Category 2?
Category 2 is health plans. This includes your typical health insurance companies, HMOs, company-sponsored health plans, and government programs like Medicare, Medicaid, and military healthcare programs. They hold an immense amount of data, so they are heavily regulated.
And the third category?
The third category is healthcare clearinghouses. These are essentially the invisible middlemen of the medical world. They're entities that take non-standard health information and process it into a standard electronic format, or vice versa. They sit right between the doctors and the insurance companies to make sure the billing codes translate correctly.
Okay, so hospitals, insurance companies, and billing middlemen, that seems like a pretty contained list. But the law doesn't just stop at their front doors, right? It casts a much wider net to catch all the secondary vendors who support those big institutions.
Yes, and this is where the web gets incredibly complex. The law extends its reach through the concept of the business associate. A business associate is defined as a person or an organization that performs certain functions or activities that involve the use or disclosure of protected health information on behalf of, or provide services to, a covered entity.
So if a hospital realizes they are totally out of their depth with data storage, and they hire an outside tech giant to manage their cloud infrastructure, that tech giant becomes a business associate.
Exactly. Or consider a third-party medical billing company that processes claims for a small dental practice. Or an outside law firm hired to defend a surgeon in a malpractice suit, which requires them to review hundreds of patient files. Or a document shredding company hired to destroy old paper archives. Because they are handling the PHI on behalf of the covered entity, they are business associates.
And I imagine they can't just operate on a friendly handshake and a promise not to peek at the files.
Definitely not. The law requires a formal, highly specific written contract called a Business Associate Agreement, or a BAA. This legally binding document stipulates exactly what the business associate can and cannot do with the PHI.
Okay.
Crucially, signing a BAA legally forces the business associate to comply with the HIPAA security rule and portions of the privacy rule. They are now subject to direct audits and fines from the federal government, just like the hospital is.
Wait, does it go even further? What if the outside tech giant hires another smaller company to handle the physical hard drive destruction for their servers?
The chain of liability continues. If a business associate hires a subcontractor to perform a service that involves the PHI, that subcontractor is also on the hook. The business associate must sign a downstream BAA with the subcontractor. It creates an unbroken chain of contractual accountability, no matter how far away from the actual doctor's office the data travels.
It really is a massive tangled web of accountability. But I want to reiterate the initial point because it is so important for the listener to grasp. Let's say I design a brand new fitness tracking app. A consumer downloads my app directly from the App Store, and they manually input their weight, their daily calorie intake, and their heart rate data. My app company has zero relationship with their doctor and zero relationship with their health insurance plan. Am I governed by HIPAA?
In that specific scenario, no. You are a direct-to-consumer technology company. Because you are not a covered entity and you're not operating as a business associate on behalf of a covered entity, federal HIPAA laws generally do not apply to the data your app collects, even though it is clearly health data.
Wow.
Now, the Federal Trade Commission, the FTC, might come after you for deceptive data practices, and state laws might apply, but HIPAA does not. The data must touch the specific ecosystem of covered entities and their associates for this particular federal law to activate.
That is a staggering realization. The exact same piece of data say, my heart rate is fiercely protected by federal law if it's recorded on my cardiologist's iPad, but it might be legally sold to advertisers if it is recorded on my personal smartwatch app.
That is the modern paradox of health privacy, and it's a tension point we're going to explore deeply as we get into the digital frontier later on.
Let's transition into the actual data itself. We're moving into section 2 of our research outline, deconstructing PHI. We keep throwing this acronym around protected health information. But what exactly makes a piece of random data elevate to the level of PHI? The CMS source provides a very specific, multi-pronged definition. It says PHI is information that, number one, identifies a person, number two, relates to their past, present, or future physical or mental health condition, the provision of health care to them, or the payment for that health care, and number three, it is held or transmitted by a covered entity or business associate.
That three-part test is the golden rule. But that first part, the phrase identifies a person, is where things get incredibly granular, mathematically complex, and frankly really interesting. Because in the era of big data, identifying a person isn't just about knowing their name and their social security number.
Not at all. We pulled the official safe harbor list of the 18 specific identifiers from the California Department of Healthcare Services. If a data set contains any of these 18 things, it's generally considered identifiable PHI. If you strip all 18 away, the data is considered de-identified and is no longer subject to HIPAA.
Right.
It is fascinating to see what legally constitutes a health identifier. I'm not going to read all 18 in a row because it's exhaustive, but let's break them down into conceptual buckets.
Yeah.
The first bucket is the obvious stuff. Identifier number 1 is names. Identifier number 6 is social security numbers. Identifier 7 is medical record numbers. We all understand why those are protected. But the second bucket, the geographic data, is where my mind was totally blown.
The geographic restrictions are some of the most rigorous parts of the law. Identifier number 2 prohibits the inclusion of all geographic subdivisions smaller than a state. This means you cannot include a patient's street address, their city, their county, their voting precinct, or their zip code in a de-identified medical data set.
But wait, back up. I understand why my exact street address gives away my identity. But if I live in Los Angeles, there are millions of people in my city. Why is the city name or a standard zip code considered a protected medical identifier?
What's fascinating here is the statistical reality of how easy it is to re-identify someone. Let's say I release a de-identified database of hospital patients. I remove their names and social security numbers, but I leave the zip code, their gender, their birth year, and their diagnosis. Let's say it's a very rare form of leukemia.
Go ahead.
If that zip code belongs to a dense urban area like downtown Manhattan, maybe there are a dozen people with that exact profile.
Oh.
But what if that zip code belongs to a tiny rural town in Wyoming with a population of 800 people?
Oh, I see.
If I know the zip code is 82001 and the patient is a 45-year-old male with rare leukemia, I could probably figure out exactly who that is just by asking around town. The triangulation of seemingly harmless data points is what the law is trying to prevent.
And the sources actually highlight an incredibly specific mathematical exception they make for zip codes to combat this exact rural triangulation problem.
Yes, the 20,000-person rule. If an organization is trying to safely de-identify data, they are allowed to use the first 3 digits of a patient's zip code, but only if, according to the current Census Bureau data, the geographic unit formed by those 3 digits contains more than 20,000 people.
Wow.
Yeah, if that 3-digit zip code area contains 20,000 people or fewer, it's deemed too statistically risky, and the entity must change those 3 digits to 000 in the dataset.
That is wild. It really highlights how anonymity is strictly a numbers game.
It is entirely a numbers game, and we see the exact same logic applied to the third identifier, dates.
Right. Identifier number 3 covers all elements of dates directly related to an individual, except the year. So you can't have a specific birth date, a hospital admission date, a surgical discharge date, or a date of death. You can say a patient was born in 1980, but you can't say they were born on March 14th, 1980. And there is another mathematical cap here regarding age, isn't there?
Yes, you can list a patient's age in years,
Ah.
up to a point. But the law mandates that all ages over 89 must be aggregated into a single generic category of 90 or older.
Let me guess. Because living to be 95 or 100 is statistically rare enough that it becomes an identifying characteristic.
Exactly. If a local hospital releases a data set showing a 103-year-old female was treated for a broken hip, anyone in that community could likely identify her, because there might only be 103-year-old woman living in the entire county. The data becomes a fingerprint.
Okay, let's move to the next bucket of identifiers. Identifiers 4 through 11 cover the typical communication and account numbers, telephone numbers, fax numbers, electronic mail addresses, health plan beneficiary numbers, account numbers, and certificate or license numbers. But then we get to identifier number 12, and this is where I want to pause and heavily emphasize this for our listeners focused on medical transportation. Identifier 12 is vehicle identifiers and serial numbers, including license plate numbers.
If we connect this to the bigger picture of logistics and non-emergency medical transportation, this is an absolute bombshell of a rule. A license plate is a piece of metal bolted to a car. But under HIPAA, a license plate number recorded in a hospital parking log or listed on a medical transport dispatch sheet is treated with the exact same level of legal protection as a patient's blood type or a psychiatric evaluation.
Why? Walk me through the logic of how a license plate becomes medical data.
Imagine a specialized medical transport van pulling into the dedicated drop-off zone of a highly specific clinical facility, let's say a pediatric oncology center or a methadone clinic for substance abuse treatment.
Okay, very specific locations.
If a third party or even a sloppy dispatcher logged that specific license plate arriving at that specific facility at a specific time, and that plate is linked to a specific patient's transport file, you've just definitively linked an individual to a highly sensitive medical diagnosis. The license plate is the physical proxy for the patient's identity.
That is deeply profound, especially when you think about automated license plate readers and GPS tracking in modern fleet vehicles. But the identifiers don't stop at physical vehicles. Identifiers 14 and 15 pull us squarely into the digital footprint. They protect Web Universal Resource Locators, or URLs, and Internet Protocol, or IP address numbers.
Which means the digital exhaust you leave behind when you're browsing the internet is heavily protected, provided it is collected by a covered entity. If you log into your hospital's patient portal from your home computer, the hospital servers log your IP address. Because that IP address is now intrinsically linked to your medical file on their server, that IP address is PHI. It cannot be sold, shared, or exposed without severe penalties.
Identifier 16 sounds like something out of a sci-fi movie, but it is very real today. Biometric identifiers, including finger and voice prints.
Think about how many times you call a massive hospital network and you interact with an automated, AI-driven voice system. Please state the reason for your call.
Right, every time.
The acoustic signature of your voice is unique. If that audio file is stored alongside your medical inquiry, your voice print is protected health information.
Identifier 17 is full-face photographic images and any comparable images. And 18 is the lawyer's catch-all. Any other unique identifying number, characteristic, or code. It is an exhaustive, incredibly comprehensive list. But let me challenge this for a second. With a list this strict, how does the real world actually function? Because the law can't demand impossible absolute perfection, right? If I walk into a bustling emergency room, I am going to see other people, I am going to hear things. Is the hospital committing a HIPAA violation every time a patient sneezes and another patient hears it?
That is a very pragmatic question, and the regulators anticipated it. The CMS guidelines explicitly discuss a concept they call incidental disclosures. The law requires organizations to implement reasonable policies and safeguards to protect PHI. But it does not demand a magical, impenetrable cone of silence in every single situation, because attempting to guarantee complete, absolute privacy would literally paralyze the delivery of healthcare.
Give me an example of an incidental disclosure that doesn't trigger a massive federal fine.
Let's picture a typical hospital scenario. A visitor is walking down a busy hospital corridor. As they pass a semi-private room, they overhear a brief snippet of a private conversation between a doctor and a nurse discussing a patient's lab results. Or, let's say a medical transport driver walks up to a busy clinic's front desk and glances down, accidentally seeing the name of the patient who signed in right before their client. These are considered incidental, accidental disclosures.
And the hospital isn't at fault.
They are not considered HIPAA violations, provided the facility had reasonable safeguards in place.
Define reasonable.
Reasonable means the doctor and nurse were speaking in normal, hushed tones in a clinical area, rather than shouting the lab results across a crowded public cafeteria. Reasonable means the front desk sign-in sheet only asks for a name and arrival time, and maybe the receptionist uses a black marker to cross out names as people are called back, rather than having a sheet that lists the patient's name, social security number, and full diagnosis sitting wide open on the counter. It's about demonstrating a culture of risk reduction and reasonable effort, not demanding impossible perfection.
That makes a lot of sense. It grounds the law in reality. So we've established how fiercely the government protects this data and how granular the identifiers are. But that naturally begs the question, if my data is locked up so tight behind all these administrative and technical safeguards, how on earth do I, as a patient, get my hands on my own records? Which brings us to Section 3 of our outline, empowering the listener and the patient's right of access. Because HIPAA isn't just a defensive shield keeping information away from hackers, it is also a legal key that guarantees patients can see their own data.
This is perhaps the most empowering aspect of the entire HIPAA framework, and unfortunately, it's one of the least understood by the general public. According to the accountable HQ compliance sources we reviewed, patients have a robust, federally protected right to inspect and obtain a copy of their PHI. And this right specifically applies to a concept called the Designated Record Set, or the DRS.
The designated record set, that sounds very formal. What exactly is in that set? Does it include every single email a doctor ever wrote about me?
Not necessarily every email, but it is remarkably comprehensive. A designated record set specifically means the group of records that a covered entity actually uses, in whole or in part, to make decisions about you.
So if they use the data to decide my fate, I get to see it.
Exactly. For a healthcare provider, this typically includes your clinical information in the electronic health record, your full medical history, physical exam notes, laboratory test results, radiology imaging reports, medication lists, and discharge summaries. For a health insurance plan, the DRS includes your enrollment records, billing files, claims records, and explanations of benefits. If that information factored into a decision regarding your treatment, your diagnosis, or the payment of your claims, it belongs to the DRS, and you have an absolute legal right to demand access to it.
Are there any carve-outs? Are there things completely excluded from my right of access? What if a doctor writes something really unflattering about me in their personal notebook?
There are a few very narrow, highly specific exceptions where your right of access does not apply. The two major categorical exclusions are psychotherapy notes and legal information.
Let's unpack the psychotherapy notes. Why can't I see those?
Under HIPAA, psychotherapy notes are defined very specifically as a mental health professional's personal private notes documenting or analyzing the contents of a counseling session. Crucially, to be excluded from your right of access, the clinician must intentionally keep these notes physically or electronically separated from the rest of your general medical record.
Oh, they have to be kept separate.
Yes, they are considered the therapist's private workspace for processing the session, not clinical directives. Your general medical record will still show your diagnosis, your prescription history, and the dates of your therapy sessions. You can see all of that. But you do not have an automatic federal right to demand the therapist's private processing notes.
Okay, that makes sense from a psychological safety standpoint. What about the legal exclusion?
You do not have the right to access information compiled in reasonable anticipation of, or for use in, a civil, criminal, or administrative legal action or proceeding. If you're suing the hospital, you can't use a HIPAA right of access request to bypass the standard legal discovery process and peek at their defense strategy notes.
That seems fair. Let's talk about the logistics of actually getting these records, because our sources highlight this as a massive area of recent federal enforcement. Let's say I submit a formal request to my hospital for my complete designated record set. How long do they have to give it to me? Can they just put me on hold for 6 months?
Absolutely not. Under the timely access requirement of the privacy rule, the covered entity must provide access as soon as possible, and they have a hard, unforgiving deadline of no later than 30 calendar days after receiving your request.
Let me emphasize that for the listeners dealing with logistics, that is 30 calendar days, not 30 business days. Weekends and holidays count against the clock.
They absolutely do. The clock starts ticking the moment the request is received.
But let me plead defense for the hospitals for a second. What if a patient requests 30 years of complex medical history from an ancient legacy archive system that involves pulling physical boxes out of a dusty off-site warehouse? What if they genuinely physically cannot meet that 30-day deadline?
The law isn't entirely without mercy. If a facility encounters a legitimate, unavoidable logistical hurdle, the law allows them one, single 30-day extension. But they cannot just ghost the patient and assume the extension is granted. They have to play strictly by the rules to get that extra time. They must provide the patient with a formal written statement explaining the specific reasons for the delay, and they must provide a firm, concrete date by which they will actually fulfill the request. They only get to pull that lever once. After 60 days, they are in direct violation of federal law.
Let's talk about the money. We all know healthcare is expensive. If I request a massive file, can the hospital's billing department hit me with a $500 invoice for administrative processing and retrieval?
No, and this is an area where hospitals get fined all the time. The fees charged to a patient for their own records must be strictly legally cost-based.
What does cost-based actually mean in practice?
It means the facility can only charge you for the actual, tangible cost of fulfilling the request. They can charge for the specific labor of the person sitting at the copier or generating the digital file. They can charge for the physical supplies, like the ream of paper if you demand printed copies, or the cost of a USB thumb drive if you want it digitally. And they can charge actual postage if you ask them to mail a heavy box to your house.
So what are they prohibited from charging?
They are absolutely prohibited from charging you generic search or retrieval fees. They cannot charge you for the time it takes their archivist to hunt through the basement to find your file. Furthermore, with modern electronic health records, the federal government has heavily cracked down on per-page fees. You cannot charge a patient a 25-cent per page fee to generate a 1,000-page digital PDF when it only took a clerk 3 clicks of a mouse to export the file.
It is incredibly empowering to know those rules. But let's flip the script. We know patients have the right to get their data. But what about when society or the government desperately needs that data? Are there times when a doctor can share your protected health information without asking you and without your consent?
Yes. The privacy rule is not a suicide pact. It recognizes that there are moments when the strict veil of individual privacy must yield to broader public necessity. The law outlines what are known as the 12 national priority exceptions. These are highly specific situations involving public interest and benefit activities where your PHI can be legally used or disclosed without your authorization, and in some cases, even without your knowledge.
A dozen exceptions sounds like a lot of loopholes. Can we group them conceptually? I don't want to just read a dry legal list, but I want the listener to understand the flavor of when the government can peek behind the curtain.
The best way to understand the 12 exceptions is to group them into 3 main buckets: public health and safety, legal and judicial actions, and extreme medical emergencies.
Okay, let's start with the public health and safety bucket. What lives in there?
This is where you find the provisions that allow society to function safely. It includes disclosures required by law and disclosures for overarching public health activities. For example, if a patient is diagnosed with Ebola or a novel strain of tuberculosis, the hospital does not need the patient's permission to report that diagnosis to the CDC or the local health department. Tracking and containing deadly disease outbreaks supersedes individual privacy.
That makes total sense.
This bucket also includes mandatory reporting for victims of abuse, neglect, or domestic violence, specifically child abuse. A pediatrician doesn't need a parent's permission to report suspicious injuries to Child Protective Services. It also covers health oversight activities, like government auditors investigating a clinic for massive Medicare fraud.
Okay, society needs to protect the vulnerable and track plagues. What about the second bucket, legal and judicial actions?
This bucket covers the intersection of healthcare and the justice system. It allows hospitals to disclose PHI in response to formal judicial and administrative proceedings. If a judge signs a court order demanding your medical records for a personal injury lawsuit, the hospital must comply, regardless of whether you signed a consent form. It also covers law enforcement purposes. If a suspect with a gunshot wound stumbles into an emergency room, the staff can notify the police without violating HIPAA. It also includes essential government functions, which can encompass national security intelligence activities or protecting the president.
So if the Secret Service needs to know if someone is a psychiatric threat to the president, HIPAA isn't going to stop them. What is the final bucket?
The final bucket deals with extreme medical emergencies and specific physiological processes. It allows doctors to share information to prevent or lessen a serious and imminent threat to the health or safety of a person or the public.
Hmm.
If a psychiatric patient explicitly tells their doctor they've planted a bomb in a specific building, the doctor can and must alert the authorities. This bucket also covers functions concerning deceased persons. A hospital can share records with a coroner or medical examiner to identify a body or determine the cause of death.
Wow, okay.
And beautifully, it covers the cadaveric organ, eye, or tissue donation processes. When a tragic accident happens and time is measured in minutes, transplant organizations don't have time to navigate complex privacy waivers to see if an organ is a match to save another life. Finally, this bucket includes very strictly controlled parameters for medical research and disclosures required for workers' compensation claims.
That is a very specific, heavily bounded list. But going back to the individual patient, when I walk up to the medical records desk and demand my file under the right of access, the hospital still has to verify that I am actually who I say I am, right? They can't just hand my file to anyone who claims to be me.
This raises an important question, and frankly, it is one of the biggest tension points in the compliance industry right now. We are constantly navigating the delicate balance between fiercely protecting privacy and ensuring that patients have frictionless, easy access to their own data. The law states that entities must follow reasonable identity verification procedures. Obviously, you don't want a clinic handing your sensitive psychiatric file to an investigative journalist or a nosy neighbor who happens to know your birth date.
But where is the line? How much proof is too much proof?
The verification process has to be balanced and proportional. It absolutely should not be weaponized and used as an unreasonable administrative hurdle to delay or deny your access.
Give me an example of an unreasonable hurdle.
The Accountable HQ Guide is very clear on this. Let's say a patient moved across the country, from New York to California. They request their old records from their New York clinic. If the clinic demands that the patient physically fly back to New York and show up in person with a photo ID to prove who they are, when secure, two-factor authenticated electronic portal options are perfectly feasible, that is an unreasonable hurdle. Or, if a clinic demands that a standard written records request must be notarized by a legal notary public before they will process it, that is considered an unnecessary barrier. Demanding notarization actually violates your right of access under HIPAA.
I love that. You protect the data, but you don't build a fortress so thick with walls so high and moats so deep that the patient themselves cannot get back inside to retrieve their own property.
Beautifully stated. The data ultimately serves the patient.
Okay, we have laid a massive foundation. We understand the history, the identifiers, the exceptions, and the rights. It's time to transition to the core of our deep dive today. This is where we take all of these massive federal regulations, all these technical safeguards, and apply them directly to the listener's specific, custom-tailored interest. Medical patient transportation, specifically the world of non-emergency medical transportation, or NEMT.
This sector is incredibly fascinating to analyze through a compliance lens. Medical transportation sits at a truly unique, highly volatile intersection between healthcare and logistical operations. These dispatch teams and fleet drivers are working around the clock, routing vans to specialized clinics, massive hospital complexes, physical rehabilitation centers, and dialysis facilities. They are interacting daily with patients who are vulnerable, who are recovering from major surgeries, or who are managing very sensitive chronic medical conditions. It operates like a taxi or logistics company, but its cargo is human beings, and its operational data is steeped in highly protected healthcare information.
So let's address the elephant in the room, the big overarching question. Does HIPAA actually apply to a medical transport company? If I own a fleet of wheelchair-accessible vans, am I bound by the same federal laws as a neurosurgeon?
The reality is, it depends entirely on the specific legal and business relationship dictating the ride. To understand this, we have to look at two entirely distinct scenarios. Let's call them Scenario A and Scenario B.
All right, let's start with Scenario A, the contracted provider. How does this work?
In Scenario A, a medical transport provider does not work directly for the patient. Instead, they are contracted directly by a hospital system, a specialized clinic, a massive dialysis center, or a government health plan like Medicaid. In this model, the hospital's logistics desk sends the patient's information, pickup location, and mobility requirements directly to the transport company's dispatch system in order to execute the transportation service.
Which means the transport company is receiving PHI directly from a covered entity.
Precisely. And because they are receiving that PHI to perform a service on behalf of the covered entity, the transport provider is legally functioning as a business associate.
Which brings us right back to that complex web we discussed earlier. They need that business associate agreement, the BAA.
Correct. Before the transport company can take a single ride, the hospital's compliance department will require them to sign a BAA. Once that ink is dry, the transportation company is legally bound by federal statute to comply with the applicable HIPAA privacy and security rules. They must conduct risk assessments, they must formally train their drivers and dispatchers on privacy protocols, they must secure their digital dispatch data, and they are subject to direct audits, enforcement, and massive financial fines from the federal government if they fail to protect that data.
Okay, that is crystal clear. Contracted equals business associate equals HIPAA applies. But what about scenario B, private paid transportation? Let's say I, as a private citizen, just go online and hire a specialized wheelchair-accessible transport van to take my elderly mother from her house to her weekly oncology appointment, and I pay the company directly out of my own pocket with a credit card. The hospital didn't arrange it. Medicaid didn't pay for it.
Scenario B is where the legal gray areas emerge. In this scenario, the transport company is providing a direct-to-consumer retail service. They're acting much more like a specialized taxi company. Because they were not hired by a covered entity, and they are not acting on behalf of a covered entity, they're likely not legally bound by the federal HIPAA statutes for that specific transaction. Technically speaking, the federal law does not cover them for that private pay ride.
But, and I assume this is a massive but, just because the federal HIPAA police might not have jurisdiction, that doesn't mean the driver can just snap a photo of my mom, post her medical destination on Facebook, and say, taking another cancer patient to chemo, right?
That is the crucial distinction. Even when federal HIPAA statutes do not legally apply by the letter of the law, HIPAA-aligned practices are the absolute, non-negotiable professional standard in the medical transportation industry. Period. Healthcare facilities expect and frankly demand that transport providers behave as if HIPAA applies at all times, regardless of who is paying for the ride.
Because the hospital doesn't have time to verify the billing structure of every van pulling up to their loading dock.
Exactly. If a transport company's drivers are sloppy with privacy, if they are loud in the waiting rooms, or leaving manifests visible on their dashboards, the clinical facilities will simply ban that company from operating on their premises. Furthermore, private clients will instantly lose trust. And from a legal standpoint, even if federal HIPAA doesn't apply, state-level consumer protection laws, general privacy torts, and deceptive business practice laws almost certainly do. So operating a medical transport business with a strict confidentiality by default mindset isn't just a best practice. It's the only viable, economically sustainable way to run the business.
Here's where it gets really interesting for the listeners running these logistics operations. Our sources identify what we can call the 5 major privacy risks specifically found in the daily operations of medical transportation. I want to break these down thoroughly because they're incredibly practical and relatable. Let's start with risk number 1, conversations in public areas.
This is perhaps the most common daily vulnerability. Drivers and transport staff are constantly physically moving through high-traffic public spaces. They are navigating crowded hospital waiting rooms, busy clinic lobbies, tight elevators, and public sidewalks. It is incredibly easy, and often entirely accidental, to impermissibly disclose PHI just by opening your mouth to do your job.
Let's build a scenario. Imagine a transport driver. Let's call him Dave. Dave walks into a packed, incredibly quiet waiting room at a massive regional hospital. He needs to find his passenger. He walks up to the receptionist and announces in a booming voice, "Hey, I'm Dave with City Transport. I'm here to pick up John Smith for his trip over to the oncology center." To Dave, he is just being efficient and doing his job. But from a compliance standpoint, Dave just committed a massive breach.
Dave just committed a textbook privacy violation. In front of 20 strangers sitting in that quiet waiting room, Dave just definitively linked a patient's full first and last name to a highly specific, very sensitive medical condition oncology cancer treatment. Those strangers didn't need to know John Smith had cancer, but now they do because of a logistics driver.
So how do we fix Dave? What is the solution?
The solution is rigorous training on the concept of minimal language. Transport staff must be trained to operate like discreet concierges. The best practice is for the driver to approach the front desk, quietly show their dispatch credential, and ask the receptionist to alert the patient. Or, if the driver approaches the patient directly, they simply say, "Hello, John, I'm Dave, your ride is here," or "We're all set to head to your appointment." There is absolutely zero operational need to announce the clinical destination, the name of the specialty clinic, or the patient's underlying condition out loud in a public space. Less is always more.
That is such a simple, elegant fix. Just train them to stop talking so much. Let's look at risk number 2. Unsecured paperwork. In an increasingly digital world, patients still travel with a lot of paper. They have printed appointment notes, specialized medical instructions, or multi-page discharge summaries from the hospital.
And those physical documents are incredibly dense with PHI. They contain names, birth dates, lists of prescribed narcotics, surgical histories, you name it. The risk in transportation happens when the chain of custody breaks down. Let's go back to our driver, Dave. Dave is driving a patient home from a complex surgery. The patient is groggy and hands Dave their discharge folder to hold onto. Halfway home, Dave stops at a gas station to fuel up the van. He leaves the discharge papers sitting wide open, face up on the passenger seat, locks the van, and runs inside to buy a cup of coffee.
And someone walks by the van, looks through the window, and reads the paperwork. Dave just committed a federal privacy violation for a cup of coffee.
Precisely. Or worse, in the modern era, we see drivers using their personal smartphones to take unauthorized photographs of these medical documents, to text back to their dispatcher to prove a pickup was completed, or to ask a question about a drop-off address. They now have an unencrypted photograph of a medical record sitting in their personal iPhone camera roll next to pictures of their dog.
That makes my skin crawl. What is the policy fix?
Transport companies must implement and enforce zero-tolerance policies regarding physical paperwork. The default rule should be that patients maintain physical possession of their own paperwork at all times. If, due to the patient's physical limitations, the driver absolutely must handle the documents, those papers must be secured, placed in a closed glove box or a sealed dispatch folder, and they must never, ever be left visible in an unattended vehicle. And taking photos of patient documents with personal devices should be grounds for immediate termination.
Which perfectly transitions us to risk number 3. Shared devices and unprotected systems. In modern NEMT logistics, clipboards are dead. Everything is routed, tracked, and confirmed through digital tablets or smartphones.
Yes, the entire logistics backbone is digital, and that presents a massive attack surface. If a transport company is trying to save money by allowing their dispatchers or drivers to access the central patient trip logs through unsecured personal web browsers on their home computers or through personal cell phones, they are begging for a data breach.
I can picture a scenario where a transport company mounts an iPad to the dashboard of the van to run their routing software.
A mounted iPad is fine if it's properly secured. The risk materializes when that company uses a shared unpasscoded tablet. If Dave finishes his shift, leaves the tablet on the dash, and the night shift driver takes over, and that tablet doesn't require a unique role-based login. Or worse, if Dave parks the van on the street overnight, leaves the tablet on the dash, and anyone walking by with a flashlight can look through the window and read the brightly lit screen displaying the next day's entire passenger manifest names, addresses, and clinic destinations. That is a catastrophic security failure.
The technical safeguards of the security rule come roaring back. They need to be using business-controlled systems, strong passwords, automatic screen timeouts, and biometric logins.
Exactly. The device must be as secure as the data it holds.
Let's move to risk number 4, which our sources note is a classic, well-intentioned compliance mistake: over-collecting information.
This happens constantly in the transportation sector, usually driven by a misplaced desire to provide excellent customer service. A transport dispatcher taking a booking over the phone, or a driver making small talk during a ride might start probing and asking the patient or the facility for their specific medical diagnosis, thinking they are being thorough and attentive.
But under HIPAA, there's a fundamental principle called the minimum necessary standard, right?
Yes, the minimum necessary standard dictates that you should only access, use, or request the absolute minimum amount of PHI necessary to accomplish the intended purpose of the job.
So applying that to our driver, all the driver actually needs to know is the logistics of the transport. What is the pickup address? What is the drop-off address? What time do they need to be there? And critically, what is the patient's mobility level? Do they need a hydraulic wheelchair lift? Do they need a stretcher? Can they walk with a cane?
That is the exact boundary. The driver needs to know that the patient requires a wheelchair lift to safely operate the vehicle. The driver does not need to know why the patient is in the wheelchair. They don't need to know if the paralysis is from a car accident, multiple sclerosis, or a spinal stroke. Asking for the underlying clinical diagnosis when all you need are the logistical parameters is a violation of the minimum necessary rule.
It seems like collecting extra medical detail just creates unnecessary legal liability for the transport company. If you don't need it to drive the van safely, simply don't ask for it.
It creates massive liability. You cannot lose or breach data that you never collected in the first place.
Which brings us to the final transport-specific risk, risk number 5, exposed dispatch and billing records.
I think people, even executives in the logistics industry, often forget just how much inherent medical data is baked into routine, boring operational logs. They look at a dispatch spreadsheet and just see rows of names, addresses, and timestamps. They don't realize they're looking at a highly sensitive medical database.
How so? Walk me through how a spreadsheet becomes a medical record.
Let's look at the patterns. If a digital trip log or a billing invoice shows that a passenger named John Doe is taking recurring trips, being picked up at his home address, and dropped off at the Apex Regional Dialysis Clinic every Monday, Wednesday, and Friday morning for 6 months straight. That log inherently reveals John Doe's deeply personal health status. It definitively proves he is suffering from end-stage renal failure. It reveals his condition without the spreadsheet ever explicitly using the word disease or listing a medical billing code.
That is a chilling realization. The pattern of the logistics is the diagnosis.
Exactly. And if those billing records or historical trip logs are left open on a dispatcher's monitor where the delivery guy can see them, or if they are exported and stored on an unencrypted, cloud-based spreadsheet that gets hacked, the PHI is fully exposed.
If we step back and connect this all to the bigger picture, this extensive breakdown is exactly why privacy in transportation is so incredibly vital. The population's relying on NEMT, the elderly, the disabled, patients undergoing rigorous treatments like chemotherapy or dialysis. They are inherently vulnerable. A data breach in transit or a loss of dignity because a driver yelled their diagnosis across a public lobby can be just as emotionally damaging to a patient's well-being as a hacker breaking into a hospital's mainframe.
It truly is. Medical transportation is an extension of the healthcare experience. It is the connective tissue. Facilities rely heavily on these transport providers to maintain the unbroken chain of trust and security from the moment the patient leaves the hospital bed all the way until they are safely back in their living room.
This has been a masterclass in the physical realities of compliance. Let's shift gears and look at the invisible infrastructure. We are moving into Section 5, the digital frontier, focusing on telemedicine and cybersecurity. We are pulling heavily from the Accountable HQ 2025 Compliance Guide, which lays out exactly how HIPAA is adapting to our highly digitized, hyper-connected current landscape.
The shift over the last few years toward telehealth, remote patient monitoring, and decentralized care has been nothing short of monumental. And the HIPAA security rule, which was originally drafted in an era of massive desktop computers chained to desks, has had to violently flex and adapt to cover these new mobile workflows. The gold standard for compliance in 2025 and 2026 now relies heavily on adopting what the cybersecurity industry calls a zero-trust posture.
Zero trust? That sounds incredibly pessimistic. It sounds like the title of a spy movie where everyone is a double agent. What does zero trust actually mean for a healthcare network?
It is pessimistic by design. The old model of cybersecurity was like a medieval castle. You built a massive, thick wall around your network, a firewall. You assumed that anyone outside the wall was dangerous, and anyone inside the wall was safe and trusted. But with remote work, cloud computing, and mobile devices, the wall doesn't exist anymore. Zero trust essentially means the network assumes danger is always present, even inside the house.
So how does the system function if it doesn't trust anyone?
You don't just verify a user once when they log in at 8 a.m. and give them free rein for the rest of the day. You verify the user, you verify the specific device they're using, you verify the application they're trying to open, and you continually verify the context of their request before granting access to a single piece of PHI.
Give me an analogy.
Imagine working in a highly secure, top-secret government building. In the old model, you flash your badge at the front door, and then you can freely wander into any room in the building. In a zero-trust model, you flash your badge at the front door, but then you also have to scan your badge, enter a PIN, and do an iris scan every single time you want to open any individual door inside the building. The system constantly asks, are you still who you say you are? And do you actually need to be in this specific room?
That sounds exhausting, but incredibly secure. And the compliance guide also stresses that encryption is entirely non-negotiable now, particularly for telehealth.
Yes. The guide specifies the absolute necessity of end-to-end encryption for any video, voice, and chat platforms used in telemedicine. It is no longer acceptable to just secure the servers. The transmission itself must be bulletproof.
Explain end-to-end encryption for the non-technical listener. How does it differ from regular encryption?
Regular encryption might scramble the data while it travels from your phone to the company's central server, where the company can technically unscramble it, look at it, and then rescramble it to send to the doctor. End-to-end encryption means that the cryptographic keys to unscramble the data only exist on the communicating endpoints, the doctor's physical computer and the patient's physical smartphone. The data is scrambled before it leaves the phone, and it cannot be unscrambled until it reaches the doctor's screen. Anyone listening in the middle, whether it is a malicious hacker on public Wi-Fi or even the telehealth software company itself, just intercepts a stream of meaningless scrambled garbage data.
That is true privacy. The guide also emphasizes something called immutable backups. Why is the federal government suddenly so obsessed with how hospitals back up their hard drives?
2 words: ransomware attacks. The rampant rise of ransomware targeting healthcare infrastructure has been devastating. Hackers don't just steal data anymore. They encrypt the hospital's entire network and demand millions of dollars in Bitcoin to unlock it. If the hospital can't access patient records, surgeries are canceled, ambulances are diverted, and people can literally die.
So how do immutable backups solve this?
Having an immutable backup means creating a copy of your data that, by its very architectural design, cannot be altered, overwritten, or deleted by anyone, not even the system administrator, and certainly not a hacker's ransomware program. If a hospital gets hit with ransomware, they don't have to pay the ransom. They just wipe their infected servers clean and restore everything from the immutable backup. It is critical for ensuring the availability of ePHI, which, remember, is one of the 3 core tenets of the security rule.
Let's talk about the hardware itself. We have to discuss BYOD, or bring your own device. Because whether it is a highly specialized cardiologist checking patient portal messages on her personal iPhone while at her kid's soccer game, or a medical transport driver checking his dispatch app on his personal Android phone between rides, the fundamental risks are exactly the same.
BYOD is an absolute nightmare for corporate compliance officers, but it is an inescapable reality of modern life. People hate carrying 2 phones. If a healthcare company or a logistics vendor allows their employees to use personal devices, the rules governing that use are incredibly strict. They require technology called containerization.
Okay, I love a good tech buzzword. What does containerization actually do to my personal phone?
Let's use an analogy. Containerization is basically like installing a secure, impenetrable titanium bank vault inside your regular smartphone. You can use your phone normally. You can play games, scroll social media, and text your friends. But the moment you need to look at a patient's medical chart or open a transport dispatch log, you have to unlock that separate, encrypted titanium vault. The software creates a secure, isolated container specifically for the PHI, separating it completely and functionally from your personal photos and apps. The 2 sides of the phone never talk to each other.
That is brilliant. It protects the company's data without the company needing to spy on my personal text messages.
Precisely. The guidelines also mandate strict screen locks. If the phone sits idle for 2 minutes, it locks. They mandate remote wipe capabilities, meaning if you leave your phone in a taxi, the IT department can push a button and instantly incinerate the titanium vault and all the PHI inside it, without deleting your personal family photos. And there is an absolute non-negotiable ban on using rooted or jailbroken phones.
Because jailbreaking a phone intentionally bypasses the manufacturer's built-in security protections, you are intentionally breaking the locks.
Exactly. You cannot build a secure vault in a building with no doors. Connecting this all back to transportation, just as a telehealth app needs to secure data on a clinician's personal phone, a medical transport driver's tablet or smartphone needs the exact same level of device encryption, containerization, and remote wipe capability. The medium changes from a doctor's office to the cab of a van, but the standard of protection for the PHI does not waver.
That is a powerful connection. And before we move off the legal landscape, we should note that while we have spent this entire deep dive talking about federal HIPAA rules, that isn't the whole story, is it?
Not at all. A great conceptual way to think about it is that HIPAA is just the federal floor. It is the baseline minimum standard of privacy that applies across the entire country. However, state laws often act as a much stricter ceiling. States like California with the CCPA or Texas or New York have passed their own robust privacy and consumer protection laws that pose much tighter rules on how consent is gathered, mandate much faster timelines for breach notification, sometimes as short as 15 days instead of 60, and impose much harsher financial penalties.
So if a state law contradicts HIPAA, who wins?
The rule of thumb in compliance is always follow the stricter law. If a state law is stricter than HIPAA and provides more protection to the patient, the entity must comply with the state law. It requires companies, especially transport logistics companies operating across state lines, to navigate a highly fragmented legal minefield.
Which perfectly brings us to the part of the deep dive that keeps executives awake at night in cold sweats. Section 6. The cost of noncompliance. Fines, tiers, and real-world cases. We are looking at the freshly updated 2026 penalty structures from the HIPAA Journal. Before we get to the dollar amounts, who actually knocks on the door to enforce all of this? Who are the HIPAA police?
Enforcement at the federal level is primarily handled by the Department of Health and Human Services Office for Civil Rights. They are universally known in the industry as the OCR. They are the primary auditors and the ones levying the massive fines. But they aren't alone. State attorneys general also have the legal authority to issue fines for HIPAA violations on behalf of their state's residents, and they're increasingly doing so, often combining HIPAA fines with massive state-level privacy lawsuits.
What about the FBI or the criminal courts? Does anyone ever actually go to jail for a HIPAA violation, or is it always just a corporate fine?
If the violation involves the intentional, malicious theft of PHI for personal financial gain, or to cause malicious harm, say, an employee stealing patient identities to commit credit card fraud, or selling a celebrity's medical records to a tabloid, the Department of Justice steps in. They bring actual criminal charges, which can absolutely result in federal prison time.
But the civil financial penalties from the OCR are by far the most common outcome, and they're structured in a very specific way. There are 4 tiers of penalties based entirely on the organization's level of culpability. And what I found fascinating in our research is that these fines are legally mandated to be adjusted annually for inflation. For 2026, the official inflation multiplier is 1.02598. I want to walk through these tiers. What does a mistake actually cost a company in 2026? Let's start with Tier 1.
Tier 1 is defined as a lack of knowledge. This is a violation where the entity was completely unaware that the breach occurred, and more importantly, they realistically could not have avoided it even if they had exercised reasonable care. It is an unavoidable accident.
I have the updated numbers here. For a Tier 1 violation, the minimum penalty per single violation is $145, and the maximum is capped at $36,505. That seems like a slap on the wrist for a big hospital. What is Tier 2?
Tier 2 escalates to reasonable cause. This means the OCR determines that the entity should have been aware of the violation. They couldn't necessarily have avoided it with standard care, but they should have caught it. It wasn't willful neglect or intentional malice, but it was a clear administrative oversight.
The fines jump up here. Tier 2 fines range from a minimum of $1,461 up to a maximum of $73,011 per violation. Let's move to Tier 3.
Tier 3 is where the OCR starts bringing the hammer down. This is defined as willful neglect. The entity consciously ignored the HIPAA rules, or they were grossly negligent in their security practices. However, they get slightly less punished because they made a documented attempt to rectify the violation and fix the problem within 30 days of discovering the breach.
For Tier 3, the minimum penalty starts at $14,602 and maxes out at $73,011 per violation. And finally, what is the worst-case scenario? What is Tier 4?
Tier 4 is the absolute nightmare scenario for any executive. It is defined as willful neglect, but with the added criteria that the entity made absolutely no attempt to correct the violation. They intentionally ignored the federal rules, their systems got breached, and then they ignored the breach, trying to hide it, or simply refusing to fix the broken security protocols.
Are you ready for this number? The fine for a single Tier 4 violation is a staggering minimum of $73,011, scaling up to an absolute maximum penalty of $2,190,294 per single violation. Let that sink in. Over $2 million.
And this is the critical part that organizations often fail to grasp. An entity might be found non-compliant in multiple different areas at once during a single audit. The OCR might find that you lacked a business associate agreement with a vendor, and you failed to conduct an annual risk analysis, and you failed to provide basic training to your staff. Each of those is a separate violation, meaning a hospital or a logistics company could be hit with multiple million-dollar fines simultaneously.
The theory being that the fines have to be high enough to act as a genuine existential deterrent, rather than just being budgeted as a manageable cost of doing business.
Exactly. If the fine is cheaper than upgrading the servers, companies will just pay the fine. The OCR ensures the fine is ruinous.
We combed through the HIPAA Journal's historical records, and the real-world enforcement actions are genuinely shocking. It is one thing to read the tiers, it is another to see how these laws are actually applied in practice. Let's look at some specific examples. You mentioned earlier the patient's right of access and how strict those 30-day timelines are.
Yes, the OCR has made the right of access a massive, publicly stated priority. They have been conducting a sweeping, nationwide enforcement crackdown specifically targeting facilities that ignore patient requests.
It is evident in the data. There are numerous cases on this list from recent years. Places like Denver Retina Center, Arbor Hospital, and literally dozens of small private practices receiving fines ranging from $3,500 all the way up to $200,000. And what did they do wrong? They weren't hacked by an international syndicate. In many cases, they simply took too long to give patients their medical records, they ignored follow-up emails, or they tried to charge patients unreasonable fees for a PDF.
It proves a crucial point. The OCR isn't just looking for hackers holding servers hostage. They are aggressively enforcing the administrative, civil rights of the individual patient. Denying a patient their data is treated with the same severity as losing that data.
Let's talk about human curiosity, because here's a wild case regarding snooping. Yakima Valley Memorial Hospital in Washington state was hit with a massive $240,000 fine. Why? Because an audit revealed that 23 of their security guards had systematically snooped on the medical records of 419 different patients in the emergency department.
That is a classic, catastrophic failure of access controls and role-based privilege. Why on earth would a physical security guard have login credentials that allow them to view clinical, diagnostic, emergency department records? They simply do not need that information to do their jobs. The hospital fundamentally failed to implement the minimum necessary standard. If we connect this back to our transport focus, this is exactly why a transport dispatcher shouldn't be able to read a patient's psychiatric evaluation. Curiosity is human, but in healthcare, curiosity is a federal violation if the access isn't restricted.
Then there is the danger of modern public relations. Manassa Health Center was fined $30,000, their crime. They impermissibly disclosed protected health information while responding to negative Google reviews left by disgruntled patients.
You see this happen all the time when a small clinic or transport company gets defensive online. A patient leaves a scathing one-star review saying, "The doctor was incredibly rude and dismissed my pain." The clinic owner gets angry and replies publicly, "We were only firm with you because you repeatedly refused to take your prescribed diabetes medication and you missed your last 3 appointments." Boom. You just broadcasted a specific patient's medical condition and treatment history to the entire internet. That is a $30,000 Google reply. Never ever confirm a patient's identity in a public forum.
And then, of course, we have the catastrophic, headline-grabbing, massive breaches. Anthem Inc. paying a staggering $16 million settlement to the OCR, plus an additional $48.2 million in a multi-state class action. Premera Blue Cross paying $6.85 million. These incidents involved millions of compromised records. When fines hit 8 figures, what is the OCR actually punishing?
In those massive historic cases, the astronomical fines weren't levied simply because a sophisticated hacker managed to break in. The OCR punishes the lack of preparation as much as the breach itself. The investigations in those cases revealed deep systemic administrative failures. Anthem failed to conduct a comprehensive, enterprise-wide risk analysis to figure out where their vulnerabilities were. They had insufficient reviews of their own system activity, meaning hackers were inside their network for months before anyone noticed. They lacked basic technical controls to prevent unauthorized access. The fine is for the negligence that allowed the hacker to succeed, not just the hack itself.
But the threat isn't always digital. Physical negligence is still a huge expensive factor. In 2022, New England Dermatology and Laser Center paid a $300,640 settlement. For what? Improper disposal of PHI. They were taking empty specimen containers with patient names and birth dates still firmly attached to the labels and throwing them straight into the regular unsecured dumpster in the parking lot.
If we connect this to the bigger picture, analyzing all of these fines tells a very specific cautionary story. The general public, and even many executives, assume HIPAA fines are the result of highly sophisticated, malicious cyber attacks oceans, 11-style digital heists. But the data shows unequivocally that the vast majority of fines stem from mundane, internal administrative negligence.
It is the boring stuff that gets you fined.
Exactly. It is a lack of basic annual risk analysis. It is failing to track down and sign business associate agreements with your vendors. It is employees taking shortcuts because they are rushed. It is guards snooping out of boredom, receptionists getting defensive on Google reviews, or staff simply throwing printed labels in the trash instead of the shredder. It is almost always a failure of internal corporate culture and basic policy enforcement.
So what does this all mean? We have covered incredible ground today, and I want to synthesize it for our listener. We traced the history of this massive law from the paper-heavy days of 1996 all the way to the zero-trust encrypted digital telemedicine protocols of 2025. We deconstructed, identifier by identifier, exactly what makes a license plate on a van or an IP address on a home computer a heavily protected piece of health information. We explored your fierce right as a patient to demand your own data and the strict, unforgiving timelines providers have to hand it over.
And crucially, we applied all of this heavy legal theory directly to the complex, constantly moving world of medical patient transportation. We saw how something as simple as a driver's conversation in a waiting room, an unsecured discharge paper on a passenger seat, or a pattern of trips on a digital dispatch log represent massive, potentially ruinous legal liabilities.
It shows that the system is vast, but it is deeply interconnected. Whether you are logging into a secure telehealth app from your couch, sitting nervously in a doctor's examination room, or writing quietly in the back of a non-emergency transport van heading to dialysis, there is a massive, invisible federal infrastructure working silently behind the scenes. Its entire singular purpose is to fiercely guard your data, your privacy, and ultimately your human dignity when you are at your most vulnerable.
It is a remarkable system. And I want to leave you with a final, slightly provocative thought to mull over. Building on everything we've discovered today about the nature of data, we've seen that seemingly mundane data points, things like IP addresses, vehicle license plates, and even the acoustic prints of our voices, are legally considered protected health information when they are tied to a medical context. Now, take a step back and look at the technological world we are rapidly building. As our cars become increasingly smart and constantly connected to the cloud, as our wearable devices track our every single heartbeat, our sleep cycles, and our blood oxygen levels in real time, and as our smart homes constantly listen to our voices to gauge our moods and automate our lives, the distinct line between a traditional healthcare provider and a standard consumer technology company is rapidly, irreversibly blurring. Will the HIPAA of the near future have to radically expand its definition of a covered entity to include almost every single piece of technology we touch?
That is a genuinely staggering thought to end on. If my smartwatch algorithm knows I have an irregular heartbeat 3 days before my actual cardiologist does, who truly owns that privacy and what laws protect it, we will leave you to ponder that massive question on your own. Thank you so much for joining us on this incredibly detailed, custom-tailored journey through the world of privacy and transportation logistics. Keep questioning the systems around you, stay curious, and keep exploring. We will see you next time on The Deep Dive.